Why don't you give us a little overview of your journey specifically with clear aligners?
Sure. So it began probably in 2003 or four. I forget now, it's so long ago, but this has got to be 16, 17 years ago. And the whole thing was, I was already into restorative, fixed crown and bridge implant related dentistry for a decade. So I'm 27 years into private practice. 10 years in, we were talking about, the ortho component with restorative cases, comprehensive care, and how so many adults were not interested in braces. So you've got this adult that you're thinking about ortho, perio, restorative, and you've got this beautiful comprehensive care case that you could be doing. They go off to the consultation and you might have a favorable periodontal consultation. You might have a favorable endo. You're going to have the ortho consultation, but that's the one where they come back and they say, I understand, I see, but I can't wear braces. I don't want to do that. We had such a list of those people that all of a sudden it was what is there for them? Why we can't do any ortho. Now we're doing restorative perio and, cases on people who have malocclusions and crowding, but we're just not addressing the ortho when they refuse braces. One thing leads to another. Next thing I'm sitting in a course that's taught by Dr. Lou Schumann at the time, an early mentor of mine. And I left after that. At the time, it was a 2-day program. I left that course, could not believe what I saw and learned. One thing led to another. And almost simultaneously, I'm looking for education and mentorship in expansive orthodontics, because I knew I had the direction that I wanted to go, which was going to be wider and forward. In other words, develop the arches, correct malocclusion, deliver a healthy human being. So I had an idea, I just didn't have the pieces of the puzzle. And sure enough, one class after the next, and then you're learning about the capabilities. You're trying the aligners on patients as you go. And the first thing you do is you put your family and your team members in it. So, for me, that's like 50 people in aligners. And sure enough, you start to figure it out and you build a puzzle and you realize how capable they are. And we're going to explore tonight how capable they are. And now, fast forward 17 years of using clear aligners as a form of expansion. Aligners are an expansive device. And so when you think about the two worlds that exist, you have expansive orthodontics and orthopedics, and you have retractive in these two camps. While they both exist, your patients have options. And when you're thinking about the expansive camp, you have a wonderful opportunity with clear aligners. They're very capable of developing your arch width and can give you beautiful expansion. And so, that it was a perfect match, because I was looking for growth and development, expansion orthodontics, and clear aligners, fits in there beautifully.
Let's talk about the most common form of malocclusion and why that exists.
Sure. So, the most common, type of malocclusion is the crowded malocclusion. And so when you think about crowding versus spacing, those are your two largest categories out there. There's crowded, there's spacing. Well, crowding exists a whole lot more than spacing. And so when we see the crowded malocclusion, which is super common, we would recognize in that category, there's another kind of category where there's a large majority, and that would be in the deep bite. So when we think about the mouths that we look at, most of the malocclusions we see are the crowded deep bite variety. And so if you're keeping score, whether it's a day, a week, a month, or year, if you're keeping a little scorecard of what you're seeing, you're going to have very few times where you notice an adult that has a bite or a good occlusion like your typodont. In other words, if you've got your typodont in your hand and you look at it and you look at the patient in the chair, very rarely is the patient going to walk in and show you that type of bite. Now, they're going to show you different stuff. We certainly have cross bites. We certainly have open bites. We certainly have, all these other ways to describe different malocclusions, but all of the other ones are really outliers. So when you think about what you're going to see most of the malocclusion is going to be the crowded deep bite variety. And since that's the overwhelming majority out there, we'd like to be prepared to treat that all the way to a beautifully developed, healthy occlusion so our patient can have a different future. It turns out that not only is the crowded deep bite the most common of all the malocclusions, it's the most destructive. And so that's the type of bite that deteriorates the fastest. And so, a human being who has all their teeth where they belong, if you have a beautiful typodont-like occlusion, it's very protective and it'll last you a long time. Basically, the mouth will deteriorate or age appropriately with a beautiful bite. But the moment you've got a crowded, deep bite malocclusion, you would recognize changes more rapidly. So we find it in the gum tissue, recession. We see it in the teeth, abfractions, wear of tooth structure, jaw joint issues, so the bone surrounding the teeth. So whether it's tooth, gum, bone, or jaw joint muscles or dentistry we've done, when you think about anything in that mouth, it's going to age prematurely or deteriorate ahead of schedule. There's a number of ways to think about it, but the crowded deep bite does not go forward very well. And that mouth, because of the deterioration, is going to be a recurring dental patient that we're patching after patching after patching. And meanwhile, we have an opportunity to correct it. But the real pathway to correct a crowded deep bite is tooth movement. That's how you get your typodont back, by tooth movement.
So let's go ahead and take a look at a couple of crowded cases. I'm just going to go ahead and share my screen. So I'm a big fan of seeing is believing. I just want to remind everyone that please no personal audio recording of our slides. That's appreciated and under copyright. So let me go ahead and slideshow from here. Okay, terrific. I'm going to move this. Okay, so tell us a little bit about this case.
Sure. So yeah, one of our favorite patients came in almost 18 years old. He had never had orthodontics. He missed an opportunity when he was younger to be treated. And next thing you know, here he is towards the end of high school and concerned about his smile and his aesthetics, and was looking for, of course, a nicer smile. Typically, that's where the patient's chief concerns are, and the aesthetics of things and or the comfort of things. But he wasn't having any pain, so we didn't have any pain to talk about. But when he comes in and has a very narrow, crowded malocclusion like this, so he has that narrow, crowded, deep bite malocclusion, we have an opportunity to help him out. And we recognize from the photograph on the right, it comes in with a little bit of overjet too. If you don't see it, just pretend he's got a little overjet. There it is. Yep, nicest kid in the world. So he shows up with this. And so, right away we had a junior in high school on our hands, which at the junior year in high school, you have missed your window to wear braces. And so he recognizes that he would like to improve his smile, because this is not a smile that he's confident with and secure with. And sure enough, he's not interested in braces. And so braces aren't going to help him out during junior and senior year of high school either. And so if he's trying to, fit in socially, he's looking for something like, a clear aligner. And certainly we have Invisalign to work this out with, but he has a narrow, improper arch form, improper arch width, improper inclination. We could recognize that all of these teeth are collapsed in towards the tongue. He has a fair amount of crowding. Tooth 29 is a very special tooth, as you're going to see in a couple minutes, that this nice young teenager was able to use Invisalign aligners, one to the next, without auxiliaries, without any elastics, without any extra type of, special treatments. It's just one aligner to the next. And we were able to teach him how to wear it, put him on. He followed all the instructions. And over time, what we're going to recognize is that he went through all of his aligners, one to last. And you're looking at the change here from the before to the after, in that this is a 36 aligner count. He went from 1 to 36. And you're looking at the 36 aligners without a refinement. At the time it was refinement. This case is almost, it's probably 8 years old now, but this is going back a ways when we use the word refinement. So he wears 36 aligners, goes from 1 to 36. Again, no elastics, no auxiliaries of any kind. And he goes basically from what you're looking at on the left is the improper arch form at an improper arch width, with improper buccal lingual inclination, a collapsed, crowded, deep bite malocclusion, to a wide open arch that has a beautiful arch form, an appropriate arch width, excellent inclination. The teeth are upright and vertical, so we can have good vertical load in the bite, and it changes the vault on them. So we get this beautiful dentoalveolar change where we would recognize a difference in what we call loosely the home for the tongue, or we can call it in more professional words, we can talk about oral cavity volume. In other words, behind a beautiful set of teeth that's closed together is the chamber that the tongue lives in. And so, the difference from one side of the screen to the other for a patient like this would be the difference between mouth breathing and nose breathing. So on the left side of the screen, when the tongue has no room, all of a sudden, when you have your teeth together and there's a smaller chamber to live in, we experience posterior displacement. And the nice research that comes out of the sleep facilities shows that when you have a narrow arch with a high vault, you have basically a reduced amount of space for the tongue, and basically your tongue is then posteriorly displaced. So the look of the OSA patient is that they have a narrow and vaulted maxillary arch. So when we think about our sleep breathing patients, we think about, well, is the vault narrow? Is the arch narrow and the vault high? And the answer is, of course, yep, there it is. And they use the word phenotype, and the fancy word phenotype means look. So when we think about the phenotype of the sleep disorder breathing OSA patient, it ends up being very consistently a narrow arch with a high vault. And in this particular case, where you also have a little bit of that overjet, he fails to have lip seal at rest. And so having your lips sealed at rest and your tongue parked forward allows the air to pass by the tongue very nicely. So this is not only a change from having basically a horrific malocclusion that's going to deteriorate ahead of schedule. All of a sudden, what you have is a beautiful occlusion that will protect itself while it's eating all that good food he wants to chew. But also he gains a lot of room and a beautiful kind of, full space for the tongue to live in. And if the tongue is living forward and high, the air passes behind it better. So not just bad occlusion to good occlusion, also mouth breathing to nose breathing.
I'm going to ask you a couple of questions that I think is great while we have this slide up to reference to, because they're going, it's an over repeating question. Can adults' maxilla be expanded with clear aligners? How much? And then also, in expansion with aligners, are you getting bodily movement of the teeth or just tipping them? So this would be a good opportunity to address that.
Yeah. So when you're thinking about that narrow, improper arch form, improper arch width, typically the teeth are leaning towards the tongue. So a lot of times what you're looking at is a fair amount of crowding and a narrow kind of V-shaped arch with the teeth having excess lingual inclination. So the very first thing you're looking to do is upright those back teeth. And so uprighting is a significant accomplishment because you take teeth that are leaning lingual, which then when they're closing, you're going to get a lot of horizontal force on those teeth. Teeth leaning in, when they close and meet the upper teeth, all of a sudden there's a bending pressure. So we're looking to correct that excess lingual inclination. So having some uprighting is beautiful. This case, which is typical, this is not an outlier, this is typical. This is what clear aligners deliver when the technique put in place is correct. And then of course, when the compliance is delivered, this is what you would expect to find. And the amount of expansion, like sometimes the question comes in the way you read it, other times it's how much expansion. Well, how much expansion is, what does the patient need? And so the idea is we do use a transverse measurement to measure across the arch, and he measures about 28 millimeters across his arch. Now, when you have 28 millimeters across the arch, it's very narrow. When we get to the ending where all of a sudden, this is about 8 millimeters a change. And so to go from 28 to 36 puts him in an average range, because 35 to 39 is a nice range to be in where you have kind of good occlusion. So if you think about having a healthy bite, the credentials of the width are going to be about 35 to 39 millimeters. Well, you basically have the opportunity to get the amount of expansion you need. And so some of the things that apply are going to be, well, we would like to expand until there's no crowding. That's one consideration. The idea would be to do something like this without any interproximal reduction. So without polishing any teeth, this is a result where there's no IPR. So if we're not going to do any polishing, then you go for full expansion. The idea here is, did you get mostly uprighting? Sure. Are the teeth now perfectly vertically placed? We'll have an anterior view in a second to see the vertical position. Do you get mostly uprighting with a little translation? It's all woven into one movement. In other words, these teeth are going to go out to place. And so it's not robotic. In other words, we don't just upright teeth, then slide them out like this, or we don't take teeth like this and slide them out, but then we'll tip them. It's not robotic. It's more of a smooth flow. So if teeth are like this, it's going to be kind of a flow out. Now, to go from the left side of the screen to the right side of the screen, it's hard to imagine that distance would be traveled with just tipping alone. So is it only uprighting? Is there some translation? It's probably a combination of. once you have histology in the alveolus activated and moving along, you're going to get some really nice natural tooth movement until these teeth are where they belong. So I'll probably say that you have the majority of this movement being uprighting because the teeth were very lingually inclined. And there's probably a little bit of translation, but it wouldn't be in a robotic move where it's one then the other. And so what kind of percentage are we looking at? Maybe this is 75 to 90% of uprighting because the teeth was so lingually inclined. And then there's it could be a 10 to 25% of a translation movement in there. The idea is that the amount of expansion that the patient needs is the amount that's delivered. And so you're looking to expand the crowded teeth away. And so we basically expand until there's no crowding. We also expand until we have a proper arch form. We expand until we have an appropriate arch width. We expand until we have an appropriate buccal lingual inclination. The three things that we talk about are improper arch form, improper arch width, and improper buccal lingual inclination. So since clear aligners are capable, what we end up doing is we expand until that patient has a healthy occlusion. So for different people, it's different numbers. He happened to be starting at 28 millimeters. So if we can get him between 35 and 39, we have a healthy range. So the idea is, where do you meet your patient? Where are they at the start? And then what do you need to get to deliver a healthy occlusion? And then the idea there is you're going to deliver the amount of expansion that's appropriate for that patient. And it may be a significant amount. And there are cases where we only do a few millimeters of expansion, given the mild credentials. Then there are patients like this. But the outcome here, again, it's not an outlier. This is the norm. This is a consistently and repeatable type of result when you have the right technique. And this was done by a teenager in 36 straight aligners without refinement and without auxiliary.
I know everyone's curious to see about that lower tooth, number 29.
I know, my favorite tooth in the world.
Right, because a lot of people would think, and I used to think before I met you, Dr. Miraglia, was that this would need an extraction. I mean, that's what you would tend to think if you didn't know about expansion, right? That out of school, would you think this out of school that would be an expansion case? I don't want to put you on the spot.
I mean, I left dental school in 1993, and for 10 straight years, I would have looked at that picture and said, wow, if you just take out number 29, the rest of the teeth will line up because that little bit of crowding will add up to the space there. And I could line up those teeth by taking that tooth out. And that would have been the first decade, 93 to 2003. And all that was I had no clue. Right. Now, 2004, I started learning about clear aligners and then getting an education in what expansion orthodontics has to offer. And next thing you know, you find out, you learn a lot about developing the arch. And then you learn that the appliances that you're using, clear aligners, they're totally capable of developing the arch. And so we have a photograph coming up, which is the end result of expansion alone with clear aligners and no IPR. This is not an IPR case. And as most cases are not IPR cases. And so not only didn't we extract any teeth, you can count them all, they're all there. But the clear aligners were 1 to 36. He wears them straight through. He gets no elastic. That tooth doesn't have an attachment on it, and he walks himself from one to the next all the way through. So this is what one aligner to the next can deliver when you have a wonderful technique in place, because it doesn't happen by snapping your fingers or by magic. You really need a nice technique. Now you put a nice technique into that clean check, because if we're talking about Invisalign, the fancy word is clean check. But when you make the right path for this patient, you should expect this to track perfectly and have yourself done at 36 aligners. And so when he opens up that entire arch, now you have the opportunity for proper arch form at an appropriate arch width with perfect buccal lingual inclination, meaning the back teeth are no longer leaning in, they're upright, so that when he bites down, he will deliver vertical load. Vertical load is what we were built to withstand. And basically that beautiful vertical load translates into vertical load gives the tooth the opportunity to transmit that force to the bone. So now you've got your tooth through root to bone. And next thing you know, you've got somebody who's got a healthy protected bite for, decades to come with little change. The left side of the screen where all of the back teeth are leaning in and collapse, that's loaded with interferences. So on the left side of the screen, when that patient bites down, he hits in all the wrong places. He has interferences everywhere. He has premature contact everywhere. And of course, with the teeth leaning in so far, all of that load the majority of it is a horizontally loaded tooth, which we know is going to cause a lot of damage over time. And the damage, what is it going to be? Recession, abfraction, enamel wear and tear. He's going to grind the heck out of his teeth, that's for sure. So you have all of this ready to deteriorate. Meanwhile, if we just move it all, upright all the back teeth, align all the front teeth, you could have a beautifully connected, protected occlusion that has all of the components of that nice, healthy typodont-like bite. And it all begins with the foundation: proper arch form, proper arch width, and proper inclination. Now, all of those back teeth take that 8 millimeter pathway to be where they belong, and the gum and the bone remodel with them. So you have a beautiful amount of gingival tissue. This is someone we treated, I think it's 8 years ago now. I can't even believe it because you feel like everything was yesterday, but this is probably 8 years out of treatment. And to this day, you just wear the Invisalign Vivera to bed every night, and nothing's changed in his mouth since. So you get the opportunity to open it up. And then one of the considerations is the view. Like you can see in this ClinCheck model how the teeth are going to play. You could play that, right? It's going to move.
Yeah, I can play it.
So, you know, the back's going to widen. Tooth number 29 is the favorite one to watch because you're going to see that tooth just take its pathway all the way up. And it begins moving on the first aligner. Everybody's moving out and upright. And all of a sudden, the chamber for the tongue is getting much bigger. So you're solving a patient's malocclusion. You're delivering more room for the tongue. You're correcting that terrible overjet that he had there too. And next thing you know, what you have is someone who, when they close their mouth, their lips will seal at rest. The tongue has a beautiful chamber to fall into going forward, and the air is going to pass better behind it. So you're improving someone's ability to breathe well by delivering proper lip seal at the front and a better space for the tongue to live in. So it just so happens that having a good occlusion corresponds with having the right amount of room for the tongue. If your teeth are where they belong, you have the right amount of space for your tongue. If your teeth are in the crowded deep bite, you have a lot less room for the tongue. The crowded deep bite, the sides collapse and we overclose. So you think about the crowded deep bite as a compactor in both directions. The patient loses tongue space this way by the collapse in of the teeth, and they lose their space this way by the overclosing into the tongue. And next thing you know, basically you're just squeezing the tongue into a posteriorly displaced position. So what a wonderful opportunity to be able to use clear aligners, Invisalign, and take a patient who looks like that to what we're about to see is a finished smile. And there's nothing wrong with a mouthful of teeth. A little whitening gel goes in there to lighten up the teeth. You get some stain off. Everybody likes a little whitening gel. But all of a sudden you have a mouthful of teeth. He smiles gently and shows you all the teeth. That's not even an exerted, forced smile. It's just a casual, easy smile. And what do you get? A view molar to molar. His teeth fill his mouth. And it would be very difficult to do that with a restorative or aesthetic technique. If we're looking at the left side picture and say, oh, you know, we don't want to wait 12 months to do this movement. Can we have a set of veneers? Now, veneers are beautiful and people work magical things with them, you know, and then we get beautiful results. But there's no way to take that picture on the left and make it the picture on the right with a set of veneers. The porcelain will be excessive. It'll be too thick. We'll have aggressive reductions of the front teeth. We're going to have buildup on the right and left. So there's such a compromise trying to do that with an aesthetic and restorative technique, whereas all we needed to do was move his teeth where they belong. We get a beautiful occlusion for it, and we get a kid who's totally confident, totally secure, very happy, now smiling to show his teeth. So you created a wonderful occlusion, but all of the things that followed with it, the tongue space, the nose breathing from mouth breathing, the confidence and security. And then of course, you know, when you have that ability to smile, you can change your social life. And next thing you know, you're enjoying your senior year of high school instead of kind of struggling through it. So you go from struggling to thriving. You go from unhealthy to healthy. You go from insecure and shy to out and about and just totally confident and secure. And next thing you know, you have a really happy patient on your hands, happy and healthy. What a wonderful outcome. Tooth movement.
And it makes you want to go to work every day, right?
Yeah, that'll keep you coming back to the office.
Okay, so let's take a look at another, unfortunately, unhealthy man since we first met him.
Sure. Yep. So our buddy here, you can see from the smile alone, well, we're narrow and we're crowded. And so when we're thinking about arch form, there's no way to look at that smile and say, this will be a beautiful arch form like a dome, you know, that beautiful dome we expect to see. That won't be in there. We have that crowded malocclusion again, and here it is. Tooth number 7 happens to be hiding, and we have other photos coming to kind of show where that is. But the idea here is this photograph alone allows you to make a real confident diagnosis that you have an improper arch form at an improper arch width. It shouldn't be a big reach to say he's going to be narrow. And if we're thinking about 35 to 39 millimeters, where that's an appropriate distance across the arch between the molars, this guy's going to measure below that. And so with a significant amount of crowding, you're going to be narrow. And then, of course, we can see that buccolingual inclination. We look into the lower teeth are completely leaning on the tongue, but the top teeth follow them. The top teeth are angled this way. So it creates that open buccal corridor, back teeth leaning in. The bottom teeth are leaning in, and the top teeth are leaning in. It's a terrible malocclusion. And so this is going to age poorly. You know, this is the kind of malocclusion that deteriorates. And we're going to see in the other photos, this is someone who's already 26 years old, but has an amount of damage. So we take a look at the incisal edges, the lower incisors, all of a sudden we have wear and tear. The dentin is starting to show. So we've got someone doing their bruxing, clenching or grinding. The first molars, they got there earlier, but now from age 6 or 7 to 28, or here we are at 26 years old, 26 years old when we meet him, we already have the buccal cusps worn off and then a little bit of an indentation into the dentin. So here we have someone who we would easily think about, oh, well, that's a lot of clenching, grinding. We'll make a night guard. You know, we would think about a night guard. We have to protect those teeth, because if that's how your teeth look and you're 26, how are you going to be 75, 80, 85? And so by the decade, this mouth is going to deteriorate. The lingual tori are being built as we speak. Here come the lingual tori in there. So there's a lot of horizontal force on those back teeth. There's a lot of activity of the jaws. And it didn't start last year or the year before. When we think about someone like this, if this patient's never had orthodontic care, well, these are where the teeth came in. They didn't come in perfectly. He didn't have a typodont at 8 to 12 as his teeth came in, and then all of a sudden from 12 to 26, they all collapsed. His teeth erupted one by one into a crowded, deep bite, narrow malocclusion. And of course, from that time on, he's been suffering.
There it is.
And there it is, another favorite tooth. This is our favorite
Another
lateral.
extraction, right?
Another extraction. Get that out of there. So the idea is improper arch form. We've got that omega-shaped arch. Improper arch width. You know, he has about 32 millimeters between his upper first molars. And so 32 to 40 is a long way off. And so he's got, you know, beautiful tooth size. His centrals are beautiful teeth. He is slightly above average tooth size. So here you have someone with full-size laterals and this complete collapse of the upper arch into the lingual. Even the mid-palatal suture's got a little curve to it. So you got that little curve into the incisive papilla as 8 and 9 are leaning over. 7 is completely trapped out of there. So this 26-year-old had no interest in wearing braces. And of course, having worked with clear aligners, by the time I met him, I had already had about 7 years experience. And so we met him in 2010. So in 2010, we meet this young man, and he knew he didn't want braces. We already knew what the aligners were capable of doing. And we went into his case without any IPR, and of course, without extraction. I don't take out teeth. I don't think about taking out teeth. The idea is that you have an opportunity to treat a patient depending upon your focus. And so I tend to focus on the foundation, not so much the teeth. And if we just help develop the arch out, we should be able to treat our patients without extraction. And then, of course, then the IPR becomes an issue. We can think about IPR, you know, it exists and it can be a helpful tool, and IPR has a place. There are, you know, places where a little IPR can come in handy, but I don't have the, let's say, technique of doing a lot of IPR on patients. And in most cases, we don't do any. The idea is the more you're willing to treat the arch form, the arch width, and the inclination, the more movement you would do. The more movement there is, the less IPR you need. So we don't do any IPR for him either. These two cases are both examples of the power that these Invisalign clear aligners have in developing the full arch and the ability to do it without extraction and without IPR. And so these are aligner alone techniques, same as the previous patient, where there are no elastics involved, there are no expanders involved, there are no mini implants involved, no auxiliaries other than a clear aligner technique to get these teeth out where they belong. So we think about a case like this to go right to the opportunity of one aligner to the next, and he's going to use 33 of them to get to here. So 33 aligners later, he's here. And, at the time, 2010 to 11 was the time where the word refinement was used. So when you're looking at that photograph, he's able to do that in exactly 33 aligners without a refinement to get to this stage. So now we have the first molars rotated out to position. We have a beautiful arch form at an appropriate arch width. And when he's measured, and in fact, when we spend a bigger time frame in a course and we open up the ClinCheck to go through the diagnostics in there, we get the ruler out and we do a measurement. He begins at 32, he ends at 39. So it's a full 7 millimeters of first molar rotating and moving out. And next thing you know, you've got a beautiful amount of expansion, enough that tooth number 7 fits into the arch. Now 8 and 9, with the expand and procline, with the developing of the arch, even the mid-palatal suture starts to straighten out. It had a full curve through the incisive papilla. So now if the upper arch is going to give you this amount of change, you're going to find a corresponding match in the lower arch. And of course, that's where our photos are headed, in that we can take a look at the lower and it opens up and goes all the way out to where it belongs. So now you have your, beautiful arch form at an appropriate arch width, and that inclination is now corrected. Instead of having excessive lingual inclination, now you have teeth that have beautiful, appropriate, and slight inclination, which means when he closes his bite together, he delivers vertical load to all of his back teeth. So we treated him from 2010 to 11. He's going on a decade since treatment, and all he does is wear his Vivera every night to bed. And then the idea is that clear aligner alone, an expansive technique with the proper technique, and a patient who is compliant and will deliver the correct wear time, of course, all of a sudden you can have the result like this. And this is done without a refinement. This is done one aligner to the next. 33 aligners later, the patient's finished and getting retainers. And now you have someone who has a beautiful occlusion. So there's going to be less wear and tear, and you would expect his mouth to age appropriately at this point. He can use it to eat the food for decades with little to no change. That's kind of how the mouth was designed, in that if you have all of your teeth where they belong, coming together with, beautiful protected occlusion, what ends up happening is that you chew a lot of food throughout your lifetime and the mouth deteriorates very slowly. The changes in the mouth are small with a good occlusion. When you have a bad occlusion, in particular, that crowded deep bite type of occlusion, you get more rapid changes. And next thing you know, we start seeing recession, abfraction, enamel wear and tear in our 20s. This is someone who's in 26. So it's not uncommon. The general dentist knows that if they're looking at people between 25 and 30, it's fair enough that you're going to find a lot of recession, abfraction, and wear and tear of enamel and other issues, but in the 20s, and then 30s, 40s, sure. Every decade. By the time you're 25, you've already had this occlusion for almost 15 years. And so 15 years in bad occlusion is a lot of damage. That's going to wear out before it's time.
One of the questions while we have the slide up is, can you expand when large tori are present? So
sure. And so, yeah, the tori are sitting in the lingual. You're looking to do some nice dentoalveolar, all of the expansion. And we're using the word expansion, but the idea is predominantly it's uprighting. And so as you're doing your beautiful expansion or uprighting technique, you're getting the remodeling of the alveolus so that everything follows out. Yeah. And so you're going to have the same amount of gum tissue. You're not going to lose any gum tissue. If you have recession or clefting, you'll probably get an improvement. It will heal. And sometimes you get an improvement in the gum tissue when you upright the teeth, because what you've done there is you've converted a horizontally loaded tooth, which is having recession because of that, to a vertically loaded tooth, which is protected, and you can allow the gum tissue to heal. So the tori don't really interfere with anything. Probably the only thing the tori could do is maybe throw a little bit of a monkey wrench into getting an impression. And so if you had to modify the tray, let's say if you had to take a PVS to get your aligners made, you might modify your tray just to take a comfortable impression. Now, if you've graduated to digital dentistry already, you've got yourself a nice iTero element and you're scanning, well, then you scan without any regard to the tori. So the only thing I can think of in the tori being an issue is maybe you have to adjust your tray to take a PVS, but once you get that PVS, you're good. And so another good reason for a scanner. You don't have to bother with the trays anymore.
Exactly. Exactly. I was going to say,
yeah,
PVS, what's that? What's
tori
that?
Are not a problem. Yeah.
Okay. Okay. Terrific. So let's take a look at this beautiful result.
Yeah. So we take him through you know, his 33 aligners, and here you are a year later, and next thing you know, you got a beautifully protected occlusion. He has all the credentials, a beautiful arch form, a beautiful arch width, a beautiful gum line. He's got everything in place in 2011. And then, you know, this is someone we photograph over the years, but the idea is this is going to remain healthy and stable for a good long time. This was the bite we were intended to have. This is looking more like a typodont on the right side of the screen, not to mention that that right side of the screen has all of those teeth out in a beautiful position without any IPR. And next thing you know, you have a beautifully set up vertical load on all your back teeth. So every one of the interferences that might have been present on the left side of the screen is gone. So what was interference full, premature contact full, you know, a very bad occlusion on the left side, when you upright all those back teeth and you deliver that cusp into groove or cusp into marginal ridge, next thing you know, you really have a well-connected and vertically loaded bite that when you do all of your final analysis, it should need little to no equilibration. You should be in a spot where you have everything that you wanted by tooth movement. And, you know, last but not least, a very happy patient. Just again, to sprinkle a little whitening gel in there. They all seem to love that very much. You reduce the shade on the teeth. You've put together a smile that's appealing. Your patient's happy. They're comfortable. So you have happy and comfortable in the patient. You know they're healthy because not only did you deliver a beautiful bite that's going to last for decades with little to no change, you've also got more room for the tongue. And anytime you give a patient's tongue more room, good things are going to happen. And the opposite is true. Anytime you reduce the room for the tongue, bad things are going to happen for that patient. The tongue should have as much room as possible, which technically kind of means you want all of your teeth where they belong. So in the end, we'd love to have all 32 teeth where they belong. That's someone who's fully grown, fully developed, and in a position where the tongue has every bit of room that it should have to be kind of forward and high in a position where the air can flow behind it beautifully. It should be
Can
no
you
surprise.
advance, I'm
Oh
sorry.
yeah, go ahead.
Can you advance the mandible with clear aligners?
Well, the question is asked a little bit awkwardly. The idea is the clear aligners aren't advancing the mandible. The idea is that when you're developing the upper arch, you are freeing a trapped mandible. And so when you're thinking about that crowded deep bite malocclusion, that mandible is trapped back. So crowding and narrow. Now, narrow traps a mandible back in and of itself. The moment you have your canines narrow and your teeth are crowded, your mandible is basically the victim of where the top teeth are. So when you're thinking about how this all works, well, the upper jaw is really the criminal and the lower jaw is really the victim. So the upper jaw determines or allows the lower to go somewhere. So basically the mandible can only go where the upper allows it to. And if the upper jaw is narrow, that mandible is trapped back. When the upper jaw is completely narrow and crowded, all of a sudden you have a mandible that has to fit behind it. And since we look at our patients and recognize most of them are class 1 or 2, the mandible's always behind the upper jaw. Rarely is the mandible class 3, which is in front of the upper jaw. So that's a rare animal right there, the class 3. So for all our class 1 and 2 patients, basically what we have is a mandible trapped behind an underdeveloped upper jaw. Now, when you're opening up that upper jaw, wider and forward, so expand is the fancy word for wider, procline is forward. So we're doing a lot of expansion. The back teeth are tipping up and getting wider, but there's also a little bit of procline. The front teeth go forward a little bit. So expand and procline is, you know, opening up the upper arch, but the mandible will follow it forward. In other words, any amount of crowding or narrow traps a mandible. And next thing you know, as you open it all up, that mandible is going to follow forward. So the question was maybe a little more jumping to the end. Do clear aligners advance the mandible? Well, it's more the technique. So if you have the right technique, uprighting the back teeth, proclining the front teeth, the development of the upper jaw is what will release a trapped mandible. So the technique will do it. Now, the good news is that clear aligners are built to upright the posterior teeth and procline the front teeth. So when you have a tool that can do that technique, then you have the opportunity to free or release a mandible that might be trapped.
Great, thank you. Okay, so let's take a look at the before and after. It's amazing how his whole face changed.
Oh yeah, another full smile. And so with all that dentoalveolar change, you get a full smile, and in a nice, light, easy smile that's not exerted at all, we can see back to the second molar. And so all of a sudden you can see all of his teeth right across the arch instead of open buccal corridors. And the idea is that we probably should be thinking about beyond the teeth when you're looking at these two people, where's the tongue fit? You know, how does the tongue fit on the left side of the screen? It's so collapsed. Where would his tongue be? It would be posteriorly displaced, the fancy word for, you know, back. And so posteriorly displaced. But on the right side of the screen, when you open everything up, the tongue has room to come forward. So if you give the tongue a space, it'll take it, that's for sure. So now you've got a happy kid who's comfortable, and you know he's healthy because you delivered a beautiful bite, and you expect him to wear his retainer every night, which he does. And now we're ticking up to the 10th year, 10-year anniversary coming for treating that. Wow.
Wonderful. We did answer a lot of the questions as we went along, but some came up in the
Okay.
chat. What's the youngest age that you can do aligner expansion in?
So I am very comfortable with aligners at the age of 9 and above. So I have done my fair amount of mixed dentition. And so that's more of a compliance issue. You can use the aligners at any age. They're a dental-alveolar tooth movement, you know, device. And so the idea is what level are you comfortable with the compliance? 9 years old has been working great and up. I'm sure at some point I'll start an 8 or a 7 or a 6. At some point you try other ages and you work your way down. I don't know that I would dive into mixed dentition without a fair amount of, let's say, more training and having some, you know, good education before just doing it to do it. But in the mixed dentition, clear aligners are wonderful for opening up the arch.
Great. And do you replace night guards post-treatment?
Yeah, I don't have a single patient in 17 years where they got a night guard back. And so, you know, anybody could imagine how many patients have night guards in a dental practice. It's probably a significant percentage, but not one of the patients that I have treated with clear aligners gets their night guard back. And so after treatment, when they have a beautiful occlusion and they wear their Vivera retainer to bed, that's the only thing they wear to sleep. Now, what's very nice to see, having used Vivera since it's been around, it's got to be since 2010, I believe. So I'm probably going on 10 years of using Vivera. The Vivera as a retainer at night does not get worn out. And so it's very protective. And as you recognize that you've developed a beautiful occlusion and the tongue has more room, if you're breathing better, there's a fair chance you're going to do less clenching and grinding. And next thing you know, all of a sudden you see your retainer looks the same 6 months later, a year later, 2 years. So we have a fair number of patients who wear a single Vivera for 2 years before switching to the next one. So Vivera can be an 8-year retainer, 2 years each, with the, you know, as long as you've developed a beautiful technique and have your, you know, occlusion corrected and tongue space. If you've got both of those, you're in great shape. So no night guards after, you know, an expansive technique.
Okay, and our friend Dr. Jordan Dupree wants to know, what are clear aligners' main strengths and main weaknesses in terms of moving teeth?
Sure. So probably the main strength for clear aligners is expansion. They are an expansion device. So when you think about, you know, what capabilities there are, the most predictable thing that you could do with clear aligners would be to expand, to develop the arch width. So alignment is also wonderful. You can, you know, very predictably align teeth. You know, when you start thinking about molar crossbite, there's a weakness right there. So clear aligners struggle with molar crossbite. Molar crossbites usually do not correct with clear aligner alone. And so when we think about using clear aligners alone, developing the arch, expansion, beautiful, alignment, beautiful, little bits of intrusion, no problem, little bits of extrusion, no problem. You have attachments so you can get your leveling of things. But when you think about a molar crossbite, I start thinking about removable expansion appliances. So molar crossbite would be a tough one for, you know, clear aligners.
Okay, someone just wants to know, what size elastics do you recommend for patients?
So I don't really use elastics. And so, you know, if we were thinking about that first patient where you had a significant overjet, that was done without elastics. And so when developing the full arch form, the arch width, you shouldn't have to do much with the elastics. And so I use them so infrequently, but that's case dependent too. If you're going to be, if I'm involved with elastics in a few cases a year, they could be 1/4 inch, they could be 3/16, they might be 1/8, they could be medium, they could be heavy. So not only do you have sizes, but you have, you know, light, medium, and heavy. And so that's near impossible to say what is regular. It's depending upon the case, but rarely do I use them.
Okay. Are there, other than more room for the tongue, are there other benefits to the airway when expanding with aligners?
Yeah, lip seal is a big one because when you've got when you have a crowded malocclusion, there's a fair chance that you might have some overjet in there. And if you've got a deep bite with some overjet, you might have some difficulty with lip seal at rest. And so when the entire set of teeth is off and the bite is off and your musculature is off, if you don't have lip seal at rest, then the mouth is automatically leaking. And so, you know, the patients who come to mind right away are the ones with some excess overjet. And with a little more overjet, all of a sudden at rest, your lips are apart. And next thing you know, you got air there. So you could have an improvement in the lip position, that's for sure.
Are you moving away from less attachments?
Oh yeah. And so when you have, when you get, this is the progression that's happened for me, is that the moment you have your technique and you recognize what your, you know, aligner is capable of doing, and you have a technique that is simple and primarily crown movement in the uprighting category. So now I already have categories as I've worked my way down. Over the last 5 years, I started reducing my attachment count. And now I have already treated more than 50 patients without any attachments, but I also have at least 50 patients where we had just 4. And those 4, the most common 4 that we end up with are the canines. 4 canines get their little attachments, and boy, you can treat almost every case. So what I've done over the last few years is get down to 4 attachments, and in a number of cases, none. So the good news is there's a wonderful opportunity to reduce your attachment count as opposed to increase your attachment count. Now, the more complicated and difficult the movements are going to be in the ClinCheck dictate the attachments. And so I'm not looking for complicated or difficult movements. I'm looking for simple. I like a simple uprighting technique, and expand and procline is powerful enough. I already know what it can do. So I'm interested in the simplest, most predictable path because that allows me to reduce the attachment count. So now if I can get myself out of the IPR, I'm happy, my patient's happy. If I can get myself down to 4 attachments for most cases and in some none, that's happiness. And so we never put on molar attachments. I don't use them at all. The next molar attachment I put on will be the first one. So I don't use molar attachments. I know they're popular today, but I don't have any desire to be adding difficulty to my technique. So I'm not interested in molar attachments, but most of the premolar attachments are unnecessary. So you get down to a technique where canines only, and now you have the opportunity to figure out, hey, do I even need those for some cases? So reduced attachment count is next. Yeah, that's what's coming next. I would love to
And
teach everybody.
our friend and colleague, Dr. Terry Coddington, just said less attachments, little or no IPR, love it. And hope you all enjoyed tonight. I think we covered most of the questions. May not be the exact question you had, but hopefully it was in context when we reviewed our case reviews.